I'm obviously incredibly humbled and honored to be following such an august list of speakers. I'm not sure how I got myself in this position, but I'm grateful for the opportunity. I'm going to share with you some slides now really about the role of cardiac CT in clinical practice. There will be some overlap with some of the work that Professor Narula showed as it relates to the importance of plaque progression, and I'll try to make 4 predictions for the future. I do have disclosures. Most relate to our core lab work, for which I take no compensation, but I do have an institutional grant from GE, and I do give advice for which I do take personal compensation to Circle Cardiovascular Imaging and HeartFlow. So I'm very excited to be standing here before you in October 2021 for a number of reasons. First of all, after what we've all been collectively through the pandemic, this is my first trip to the United States since then, and I feel very grateful for that. But I also am very grateful because after 15 years of tremendous hard work by an entire field, I think we're finally on the verge of seeing Class 1 support for cardiac CT. I have no direct involvement with the local ACC guidelines, but I believe that the evidence is so compelling that I'm hopeful we will see that come in the near future. That evidence starts with diagnostic accuracy. There is no better non-invasive tool for the diagnosis of and exclusion from anatomical coronary disease. And I think if that is the question that you're asking when you see a patient with symptoms of possible angina but without yet known disease, I think that test that we should be considering is in fact CT. There's unparalleled anatomical accuracy, and we've seen that most recently in the Ischemia Trial, where we served as the core lab looking at over 5,000 CTs that were done in a blinded fashion to exclude stenotic left main disease and confirm the presence of a stenosis anywhere in the coronary tree. And what we can see here is that the agreement with QCA was not perfect, but it was over 97%, far superior to any other non-invasive tool as it relates to the diagnosis of CAD. Beyond that, CT not only provides you rich anatomical accuracy, it provides you rich prognostic utility. Prognostic utility that is not only powerful, but I would posit to you extends beyond traditional stress testing. It starts with the warranty period, as Professor Narula highlighted, and as he's taught me for many, many years, that atherosclerosis is the driver of incident myocardial infarction. Obviously, we heard that mechanistically from Dr. Libby as well. But what we know is that while CT doesn't provide us that sort of histopathological resolution of atherosclerosis, that a patient bereft of atherosclerosis on CT has an incredible warranty with regards to a negative likelihood ratio for incident major adverse cardiovascular event. That warranty is more powerful than traditional stress testing, and it extends, of course, much longer than traditional stress testing, with a duration of time approaching 10 years. We also know that because CT doesn't just allow us to identify stenotic disease, but rather also the presence of atherosclerosis, it uniquely contributes an opportunity to discriminate those with and without plaque. And as we see here amongst the 10,000 patients randomized within the PROMISE trial, that the patients randomized to the CT strata have a much better discrimination of risk than those in traditional stress testing. Particularly if we look at the lowest two Kaplan-Meier curves, what we see here is that the second lowest curve are those patients with plaque but no stenosis. No other non-invasive tool can provide us this information, and importantly, it's this information that informs rich prognostic utility with a threefold hazard for incident myocardial infarction. On the other hand, if we look at the slide on the right or the figure on the right, these are patients who are tested with SPECT, and you can see the two lowest Kaplan-Meier curves. You can appreciate that there's no separation of those curves. Mildly abnormal versus normal SPECT. If you have two patients waiting to see you in your clinic, you can't tell which patient is actually at a higher risk of an event. And as a result, you can also not tell which patient actually has atherosclerosis. And as I've learned from Dr. Ahmadi and Dr. Narula for some time, treating risk factors only modestly reduces events, but of course treating those patients who are identified with atherosclerosis creates a personalized opportunity to modify their personal risk. As of 2 weeks ago, we saw these data published by Harmony Reynolds. This comes from the Ischemia Trial, and this really focuses on the dose-response relationship between the extent and severity of stress testing and the extent and severity of anatomical disease by CT, and the relationship with mortality. And you can see, similar to the data we saw from COURAGE, is that the extent and severity of anatomical disease by CT angiography, was associated with an incident mortality, whereas the severity of the stress testing abnormality did not exhibit any relationship with incident mortality. So I think that CT is not only accurate, but it is prognostic. And finally, as we all know, we don't serve just to inform diagnosis or tell people that they're going to have a bad outcome, but we hope that the information that we extract informs decisions in a fashion that improves outcomes for the patients we serve. We've seen such data from CT observationally from the West Danish Heart Registry. This is 60,000 patients who are enrolled. All patients who undergo cardiac CT in Denmark are enrolled in a registry, all testing for that matter. And what you can see here is that when the cardiologist or the primary care physician manages her patient based on the results of CT, those patients experience a 30% reduction in incident myocardial infarction as compared to those patients who are treated on the basis of traditional stress tests. And again, this has nothing to do with the radiation of CT. It doesn't stabilize plaque. It's rather that it informs personalized atherosclerotic burden to help titrate and guide medical management rather than traditional stress testing, which of course provides you none of that rich information about the extent and severity and morphology of atherosclerosis. Now that's observational data, so there are obviously potential confounders, but we've also seen randomized data from Scotland, 4,000 Scots, men and women, randomized between CT and traditional care, and patients randomized to the CT arm had a 40% lower MI and cardiovascular death rate. Prediction number 2, and there's some overlap with Jagat's excellent presentation, is as far as the potential for CT to continue to help advance our understanding of atherosclerosis and risk. We know from the SCCT guidance document, which was led by Dr. Narula and Dr. Shaw, that we can offer more than simply commenting on stenosis. We can provide an assessment of the number of segments of plaque as a surrogate measure of total quantitative plaque. We can characterize some of the plaque features we've learned about now 15 years ago of positive remodeling, low density, and napkin ring. And then I think in the future, although not present, I think supported by machine learning or AI-based algorithms and sort of core lab attempted analysis, we will be able to actually quantify atherosclerosis with good reproducibility to afford us the opportunity to potentially track treatment response. So why does it matter? Well, I've learned a few things over the years and much from people in this room. It starts really that, not surprisingly, that the extent of atherosclerosis connotes risk, independent of the plaque morphology. I think all that we've learned, of course, of positive remodeling and low-density plaque is incredibly important, but what we know is that patients with more atherosclerosis are at higher risk, whether that's the number of segments or and independent of stenosis. So that some plaque is worse than no plaque and more plaque is worse than some plaque, and premature plaque is perhaps worse than both. This slide was already shared with you earlier, but I think it's so fundamentally important and which creates an opportunity for us in CT, perhaps not yet, but in the future, that we can actually look at not only quantitative plaque burden to understand risk, the presence or absence, the number of segments and the morphology, but also then use that baseline imaging to serve as an opportunity to explore personalized plaque progression or treatment response. We know that plaque progression is key. This is the 10-year data from Dr. Narula and Dr. Motoyama's work, published originally in 2009, where they taught us that these plaque features were very powerful predictors. I've also learned, though, from subsequent work that those predictors, those plaque features, are also, they align with the total extent of atherosclerosis. But beyond that, what I really took from this paper, which was really enlightening, was the fact that plaque progression was the single most important thing as it relates to incident MACE. So that when we identify a patient with atherosclerosis on a CT, it creates the opportunity to help modify treatment decision-making, modify risk factors, and ultimately, hopefully prevent incident myocardial infarction by preventing plaque progression. As we heard from Dr. Narula, the message from all of the data that we saw before really reflects on the fact that, the non-stenotic disease and incident myocardial infarction message is not so much that lesions go from mild lesions to instant rupture and coronary thrombosis, but rather the message is that non-obstructive plaque should not be ignored. When it is identified, if left untreated, it exposes the patient to an incident risk of myocardial infarction. Now, people may say, why would we not use calcium scoring to track treatment response? But we've seen very nicely over the years that, of course, calcium alone at baseline in an untreated population serves as a good measure of atherosclerotic burden because it's a tip of an iceberg. But following initiation of therapy, one can have progression of calcium really in two patterns. We can have, as shown on the bottom right, we can have calcium increasing, but the total plaque burden outstripping the rate of calcium progression. This is a very bad thing. That speaks to overall plaque progression, increasing non-calcified plaque. But similarly, if we initiate medical therapy and we have a baseline calcium score, we can see the calcium volume and the calcium score go up, but it can actually outstrip the rate of the remaining plaque progression as a manifestation of plaque stabilization, of conversion of non-calcified plaque to calcified plaque. That actually could be positive treatment response. And you can't separate those two with the calcium scoring alone. So I think that there will be opportunity in the future to explore CTA to do so. And we've worked with many others, including others in the room, to understand how we can do that, using a core lab to quantify atherosclerosis, and then look at patients who had repeat CTs anywhere from 2 to 5 years after in the Paradigm Registry. Importantly, core lab analysis, and so the applicability across the community is limited, but it has provided us insights into rates of plaque progression by CT and drivers of plaque progression or things that may be reducing plaque progression. Here, not surprisingly, what we can see is in statin-naive versus statin-taking patients, that statin-taking patients have a lower rate of plaque progression and they have a higher rate of calcium progression and a markedly lower rate of non-calcified progression, highlighting potentially the opportunity to not only explore mechanisms, but perhaps eventually get to a personalized level to understand the individual's treatment response to plaque. So you may ask, why is it that I'm a CT zealot? Why would I not say we could do it now? Well, I think there are a number of issues. First and foremost is the clinical opportunities to use such quantitation software in our practice, which is challenging because of time requirements and lack of reproducibility. But we also have to go a long way as it relates to advancing our CT protocols to ensure that if we're going to do these sorts of studies or inform clinical decision-making, that we do so thoughtfully. This is interesting work from one of our former fellows who's gone back to Japan, Hide Takagi, looking at the impact of simply changing scan parameters on plaque morphology and burden. And I don't want to get into the physics of CT, but a simple switch of the tube energy has both indirect and direct effects on plaque morphology and the volume of calcified versus non-calcified plaque. The point of this slide is just to highlight that if we are to move forward in the future with using CT as a measure of plaque burden and to titrate medical treatment, we have to do so very thoughtfully. Otherwise, our hope for improvement in downstream outcomes will not be realized. Prediction 3 is that we'll use CT to plan coronary interventions. You know, at my site and at any of the hospitals in this great city, I would imagine you would not do a TAVR without a non-invasive evaluation of the annulus. We use CT routinely to plan sizing of the transcatheter valve, and we use CT to inform the risk of procedural complications. And yet far too often, because of a historical reliance on adjudication of symptoms and stress testing to inform decisions around invasive angiography, patients patients go to the lab based on what I think is a somewhat sex and gender and ethnically biased adjudication of symptoms, and then non-invasive stress testing, which of course doesn't give you any information about the presence or absence of anatomical disease. And so our poor interventionalists go to the cath lab largely unarmed, without even knowledge as to whether or not the patient has anatomical coronary disease. And then they take the patient to the cath lab and they find a patient bereft of atherosclerosis. They radiated themselves, they gave themselves back pain, and they took a risk of the patient. Or perhaps worse yet, you send the patient has the angiogram, and then the interventionalist is faced with making decisions around ad hoc PCI in the most complicated atherosclerosis that she's seen in a week, with an NSTEMI waiting in her, waiting for her to see her in just a few minutes. This is a tall task. I think it's too tall of a task. And I think, unlike any other procedure in medicine, I think the concept of going to the invasive procedure without knowledge, without opportunity to explore and plan, it should be behind us. And the reason I say that is that complete revascularization is simply not happening frequently enough. These are data from Greg Stone, presented just this year. 40 to 60% of patients in the Ischemia Trial were incompletely revascularized. And importantly, this is associated with an increased risk of myocardial infarction. So why not go to the cath lab informed by CT, especially if CT is being used as a class 1 test to evaluate patients for suspected but not yet confirmed coronary disease? We know that we can provide fluoroscopic angles of any three-dimensional structure that we segment from a CT, whether it's the aortic annulus, the atrial septum, or the mitral annulus. As we saw from a group from Krakow and from Nico Piazza and McGill, we can do the same for left main ostium, for left main bifurcation. Again, is this going to drastically change decision-making? Perhaps not, but it's free information. How about going to the cath lab, avoiding unnecessary surprises? I don't think we should be diagnosing critical left main disease with a catheter in left main. I think the opportunity to do so is in advance, as we can see here on CT. I also think there's opportunity to understand physiology in advance of ICA. These are from Professor Sorois and Carlos Collet, highlighting that when they looked at the non-invasive anatomical syntax by CT and the invasive gold standard, there was overestimation of disease by CT alone. But when they integrated physiology, they realized that they could provide a non-invasive functional roadmap that provides anatomy and physiology that was quite similar to the invasive gold standard, thereby providing an opportunity to send a patient to the cath lab not only with rich anatomical data of a severe LAD lesion, but also information about the physiology in the right coronary artery, which exhibited a moderate to severe lesion, in this case, though, physiologically negative. Instead of going wondering, atypical chest pain, indeterminate stress test, our interventionalist now has anatomical richness of two lesions, one that's physiologically severely abnormal and one that is physiologically within the normal range, thereby going to the cath lab with a plan. Beyond that, I think there's a real opportunity to explore mechanisms of angina, but also mechanisms of improvement of symptoms following revascularization based on the physiological phenotype of disease. What we've seen from the invasive world, both IFR and hyperemic FFR, is that you can have very similar anatomical disease, and you can also have abnormal physiology, but the path to getting to abnormal physiology may be quite different. The case on the left, what you see there is a very focal drop-off in pressure. That is a very focal phenotype of physiology that is almost certainly will lend itself to focal PCI with a great likelihood of improvement of physiology. On the other hand, the case on the far right has abnormal physiology in the distal LAD, but the pressure dissipates very, very gradually without a focal step-off. Very challenging anatomy and physiology to treat percutaneously. I think, as lent to me by Carlos Collet, we can start exploring these patterns of physiology non-invasively to move beyond just this binary concept of normal or abnormal physiology, but to explore the phenotype of that physiology to better inform the likelihood of successful revascularization. And I'm also very excited about this concept that coronary volume to mass, the volume of the coronaries normalized to the myocardial mass, may create an opportunity for us to understand why some patients exhibit symptoms at a lower threshold of stenosis than others. And I think this is unique to CT because, of course, the angiogram can give you the coronary volume, but you can't normalize to the mass. And so it's one thing to have small coronaries if your demand is low, but if you have small coronaries and your demand is high, or your demand is average, that leaves you exposed to angina at a much lower threshold. It leaves you exposed to having abnormal physiology at a much lower threshold. And this is from the advanced registry, over 5,000 patients, showing that there's quite a distribution. This can obviously be driven by genetics, it can be driven by smoking, it can be driven by a sedentary lifestyle. And so one can imagine, like the image on the far right, a master athlete who exercises and trains her coronary arteries for years such that they accommodate increased flow and maintain a homeostatic level of shear stress. And so her coronaries are large, and she can accommodate her plaque, maybe not as it relates to plaque rupture, but certainly can accommodate her plaque as it relates to angina for quite some time because her coronary volume to mass, her resting flow conditions are optimal. On the other hand, if you're sedentary and you smoke, you may exhibit, or even if you're genetically predisposed and you have small coronaries relative to your demand, it does not take much of a stenosis for you to dissipate pressure with hyperemia. And that's what we saw in an exploration. Sorry, the reference is cut off. But patients with abnormal physiology, despite the absence of a 50% stenosis, almost always had low VM within the NXT registry. So interesting opportunity to explore non-invasive measures of vascular health. And finally, in closing, my prediction is that cardiac CT will continue to grow in its role in structural heart disease. I think we would all agree that the treatment of valvular heart disease has been disrupted by the advent of transcatheter interventions. And we saw over 2 years ago, even in low-risk patients, that patients who were randomized to TAVR did as well or even better than patients who underwent SAVR. And really, it's on the basis of this data that I hear many people tell me, well, shouldn't we just do TAVR on all patients? And I think what the message is from these data is that surgical risk doesn't necessarily inform the likelihood of a TAVR complication. But those that say that, I remind them to look at the appendix of these studies. We served as the CT core labs for these studies, and it's important to reflect upon, like any randomized trial, the inclusion criteria of such patients and the patients that were excluded. And so the message of the low-risk trials is that TAVR is very effective and provides comparable outcomes in low surgical risk patients, assuming you've done a CT and you've excluded adverse features. If the patient has severe subannular calcium or adverse root features, that patient is at risk of a TAVR complication. So I think that the message is that CT plays a fundamental role in screening these patients. Beyond that, we're seeing significant advancements in technology that will create opportunities to understand personalized risk of complications. This is work from Lakshmi Dasi at Georgia Tech we collaborate with, where they're doing solid state and fluid mechanic modeling, looking at the impact of balloon expandable valves on local stresses on the aorta to predict risk of annular injury. And you can see in this case, a patient who experienced a sinus perforation. It was predicted based on the millipascal peak stress exerted on the right sinus of Valsalva. They predicted not only rupture, but location. Finally, I think we can explore mechanisms of TAVR degeneration. We know that we can see hypoattenuating leaflet thickening in any bioprosthetic valve, surgical or transcatheter. And we'll see it at 30 days, we'll see it at a year. It's slightly more common in TAVR than in SAVR, but it's a disease of bioprostheses. We've tried to provide guidance as to how to classify it, the extent and severity of this halt, to provide insight as to how we can follow it and make more of it. But what I would ask is, and while we don't know if halt is meaningful, we know it's not associated with heart events, the question is, could this thrombus that we see on CT be an inciting event for structural valve degeneration? And the last 4 slides really focus on unanswered questions, but opportunities. These are data from Quebec, which highlighted that approximately 5% of patients experience premature structural valve degeneration after TAVR. And so the question is, are those patients, the 10 to 15% of patients who develop hypoattenuating leaflet thickening at a week or 30 days, are those patients disproportionately represented amongst those with structural valve degeneration? We look at, on the bench, explanted THVs, and one of my former postdoctoral fellows, Stephanie Sellers, who's now on faculty, identified that while thrombus didn't always lead to degeneration, thrombus was always present on these explanted valves when calcium was present, when fibrosis was present. So while there's obviously selection bias in that these valves are explanted, it at least raises the possibility that thrombus is the first of the building blocks to progressive structural valve degeneration. And in closing, I'm very fascinated by this excellent work from Edinburgh that fuses metabolism, pathology, and anatomical imaging with CT using sodium fluoride PET, highlighting that, as they've shown in native aortic valve disease, that when we see sodium fluoride avidity on a surgical valve in this case, that was a strong and powerful predictor of progressive valve degeneration, of rising surgical valve gradient, creating an opportunity for us to understand both mechanisms as well as predict valve degeneration. This same group actually published just a couple of weeks ago in Circulation. It was highlighted by Professor Fuster after ESC, a similar study looking at a matched comparison of surgical and transcatheter valves, highlighting that sodium fluoride avidity was also predictive of transcatheter heart valve degeneration. And amongst those who had explant or of those valves and histopathology was done at UBC, what we can see is that the degree of valve degeneration is really quite profound in these patients with sodium fluoride avidity. Importantly, the overall uptake of sodium fluoride in SAVR and TAVR appears similar, which perhaps provides some insight into a similar durability between these valves. Obviously, that needs to be explored further. So I'll close there. I think the future for cardiac CT is bright. I think there are many outstanding questions, but I have no doubt that it'll be used to a greater extent to evaluate patients with symptoms. It will provide us a deeper insight into atherosclerosis and risk, and will certainly be used on a continuous and probably a growing basis to guide structural interventions. Thank you again.